promote initiatives in education, diversity, equity, and inclusion. I could say a lot more, but to maximize our time with her, I'm going to refer you to that more detailed bio in your meeting packet and turn the podium directly over to her. Dr. Dasgupta, thank you for joining us today.
Dr. Rary, thank you so much for that warm introduction. I'm just going to take a moment here to share my slides. Okay, does this look like it's coming through for everyone?
Perfect, thank you.
All right. Well, first of all, I would really like to thank the organizers for inviting me to speak to you all today. I'm delighted to see the theme of increasing access to care through the lens of diversity and inclusion reflected in the MGN annual conference. And I'm grateful for the opportunity to share this work with you. I'm passionate about equity across a range of identities, and today I will be speaking on a project I've been working on with an interdisciplinary team of scientists and clinicians. Project Inclusive Genetics, developing a patient-centered counseling approach. So let's begin with a few definitions. Explicit biases are those that we are aware we harbor, that if someone asked a person their feelings on a particular identity group, they would openly state their opinions. Explicit bias dramatically underreports existence of biased attitudes, though, because people are often aware of the unacceptable nature of these views, and because the majority of biases are actually unconscious or implicit. Implicit biases differ because one's stated intention and values may be exactly the opposite of the way one actually unintentionally acts or behaves. Implicit bias is an attitude that you have no direct introspective access to. We all have implicit biases because we all absorb the messages conveyed to us by society. Healthcare providers manifest implicit biases to a similar degree as the general population, so it is important to have awareness of these biases in order to prevent them from influencing how we interact with others in a professional capacity. Because you may not actually be aware of your implicit biases, sometimes your intent may be good, but the impact may be one where harm is conveyed. Thus, it is important to have strategies to gain awareness of implicit biases and also to interrupt them. Left unchecked, implicit biases can cause significant harm and may contribute to healthcare disparities. Numerous studies have demonstrated that unconscious or implicit bias held by healthcare providers can strongly and negatively impact patient encounters. This phenomenon has been observed in the context of racial bias, in which provider bias contributed to false beliefs about race-based biological differences in pain perception, misdiagnosis rates by patient race, poor interpersonal communication with Black patients, and worse healthcare outcomes. There is robust research examining the negative impact of racial and socioeconomic implicit biases on healthcare provider clinical decision-making. However, there are many other understudied important biases that likely impact clinical care. In the world of genetics, many genetic diagnoses have elements of physical or intellectual disabilities, so awareness of these biases in particular have the potential to influence patient care decisions. Tying into our first trivia question, the foundation of the field of genetics is built on bias, explicit and implicit, that led to policies like eugenics, forcible sterilization, and the types of decisions that contribute to modern-day disparities. We must be vigilant to ensure that we do not repeat these regrettable aspects of our history. We must not shy away from questions about how genetic technologies will be used or what they reveal about the people that implement these approaches and the ways they are being rolled out. Particularly in the prenatal space, the availability of genetic tests allows individuals to make decisions about whether or not to continue a pregnancy based on the outcome of the test. An important question for us to reflect on is, does providing prenatal testing and opportunities for pregnancy termination for certain genetic conditions imply a belief that individuals with disabilities are defective? There is a complex relationship between reproductive rights for future or currently pregnant people and disability advocacy. Let's dive deeper into our understanding of the role of implicit bias and how it can impact healthcare with a special focus on disability. With respect to the principles of patient-centered counseling, the literature shows us that there remains a disconnect between a physician's personal views and their understanding of their role in providing guidance to patients. This may be in part due to a documented misunderstanding of the elements of patient-centered counseling, which can lead to patients not receiving balanced information from counselors. The ability to provide this type of patient support is incredibly complex, and without it, providers may unintentionally exert undue influence on patient decision-making. In other words, physicians harbor bias and submit that their beliefs should be used to persuade patients to make choices that align with these beliefs. On the patient side of things, Robert et al. Studied the perception of the quality of genetic counseling received in prenatal settings for pregnant people with a prenatal diagnosis of trisomy 21 or spina bifida. While most of the patients said they found the counseling helpful, a full 87% said they didn't receive information on the future well-being and quality of life of the child, and 83% reported they didn't receive balanced information on positive and negative outcomes. Therefore, there is still significant room for improvement in implementation of patient-centered counseling principles. Finally, in this study by Archambault et al., they examined whether there was existing bias in a cohort of physician assistant students and whether a case discussion of an elderly patient with physical disabilities had any effect on the post-discussion IAT or implicit association test results. Pre-discussion results, shown in dark green, indicate a strong automatic preference for abled individuals. 3 months after the discussion, shown in pale green, there was a modest migration of students on the disability IAT towards slight automatic preference for abled and away from the strong and moderate preference for abled persons categories. The gray bars indicate general respondents to the disability IAT on the Project Implicit website. Therefore, much like healthcare providers, trainees, in this case PA students, also harbor biases towards individuals living with physical disabilities. Together with previous studies examining racial and socioeconomic biases among students, it appears that effective educational interventions can decrease implicit association test scores, indicating a decrease in implicit bias. Given these findings, it is possible that biases generally have the potential to contribute to healthcare disparities and may be amenable to educational intervention. In summary, these examples of biases and their potential impact on patient care come from a range of providers in healthcare. There remains a disconnect between personal views and understanding the role of the physician in providing guidance to patients, which is exacerbated by the misunderstanding of the elements of patient-centered counseling. Patients are not receiving balanced information from counselors to help them make complex medical decisions, and PA students demonstrate a preference for abled individuals, suggesting that these biases are learned prior to specialized training for healthcare workers. These studies also demonstrate another key aspect of delivering care in the genetic space, that there are numerous providers with different training working with patients who live with disabilities and patients who are making reproductive decisions that are impacted by personal knowledge of disability. Because of the rapidly evolving landscape of genetic testing, many providers are engaged in this type of care beyond the typical specialist in genomic medicine. As you can see in this chart, there are multiple new genetic tests entering the healthcare marketplace daily, creating an environment of exponential growth in genetics-focused healthcare. At this rate, the need and demand for genetic services cannot be met by genetics providers alone. Caring for patients with genetic concerns has traditionally been the domain of genetic counselors and medical geneticists, but increasingly, genetics adjacent specialists, such as obstetricians, primary care providers, including pediatricians, and allied health professionals are also providing care in this space. Another factor that contributes to which providers are involved in delivering genetic services is related to availability of specialists in a local area. The Government Accountability Office Genetic Services Workforce Analysis was done in conjunction with the American Board of Genetic Counseling, American Board of Medical Genetics and Genomics, Accreditation Council for Genetic Counseling, National Society of Genetic Counselors, Association of Genetic Counseling Program Directors, American College of Medical Genetics and Genomics, and the American Society of Human Genetics. So a total who's who in the genetics world. This study was commissioned to address the fact that advances in genetic technology and research have increased the amount of information available to individuals and providers and may have increased the demand for genetic services in parallel. The medical genetics workforce, which includes genetic counselors and medical geneticists, plays an essential role in providing access to genetic services. Some studies have identified concerns with the size of the medical genetics workforce and its ability to meet the current and future demand for genetic services. Evidence from this study emphasizes that concern, identifying that states averaged 7 genetic counselors per 500,000 people in 2019. Similarly, there is a comparable issue at play with respect to access to medical geneticists, with states averaging 2 medical geneticists per 500,000 people in 2020. Genetic counselors and medical geneticists primarily practice in hospital settings, thereby also identifying access issues in rural areas. In terms of US regions, there are more genetic counselors and medical geneticists per 500,000 people in most northeastern states and some Midwestern and Western states, while most of the southern states and other Midwestern and Western states have lower proportions. According to the GAO analysis, the District of Columbia had the greatest numbers of both genetic counselors and medical geneticists per 500,000 people. 3 states, West Virginia, Mississippi, and Wyoming, had less than 1 genetic counselor per 500,000. And similarly, 12 states had less than 1 medical geneticist per 500,000 people. Of the 12 states, 1 state, Wyoming, did not have any medical geneticists listed in the data provided by ABMGG. Again, overall, states average 7 genetic counselors per 500,000 people and 2 medical geneticists per 500,000 people, according to GAO analysis. If anything, medical geneticists are even rarer than genetic counselors, leaving large segments of the country without proper provider coverage. The number of prospective genetic counselors has been steadily increasing due to expanded class sizes and founding of new training programs, but this growth is modest relative to the clinical need. The number of genetic counselors in the United States has approximately doubled in the last 10 years, but career options for genetic counselors are broad, and many are not in patient-facing roles as well. In contrast, the number of medical geneticists appears to be holding steady, so this is not currently an area of growth that may serve to meet increasing clinical need. With respect to patient access to a medical geneticist, this study has documented an increasing wait time to see a geneticist for non-emergency care over recent years. The data were first collected in 2003, the year the Human Genome Project was completed. In comparing the 2019, 2015, and 2003 data, the findings demonstrate that new patient non-emergency appointment wait time has increased. 39% of new non-emergency patients are waiting more than 3 months to be seen by a clinical geneticist, compared to 30% in 2015 and 11% in 2003. Estimates indicate that this phenomenon is not unique to medical geneticists, but applies across all disciplines of respondents as well. It has become routine to wait over 3 months to see a geneticist as caseloads expand, but capacity to see new patients does not. For these reasons, it is increasingly critical to develop an interdisciplinary workforce that can meet the rapidly expanding need for genetic services. This group of healthcare professionals have varied levels of exposure to the principles behind offering patient-centered genetic care in their formal training programs. By creating continuing education opportunities, we can help equip providers who are faced with delivering genetic services with the tools they need to equitably deliver patient care. This infographic emphasizes the common nature of living with disability in the United States, impacting aspects of life including mobility, cognition, hearing, and vision. When we consider intersectionality with race and ethnicity, we can see that members of certain marginalized populations are disproportionately made more vulnerable by their disability status, but all racial and ethnic groups do include many people living with a disability. These statistics demonstrate that healthcare providers are not representative of the general population in these dimensions. Certainly, there are many other aspects of identity. I am only focusing on these 2 elements, race and disability status, for the moment. As we can see here, the medical genetics workforce, as defined by medical geneticists and genetic counselors, does not fully reflect the diversity of the patients they serve. The professional communities of the medical genetics workforce have begun grappling with what can be done to address the historical exclusion of these groups and others from training in this specialty. But we need to create an inclusive workforce before those graduates enter the profession. Because lived experience is missing for many of these providers, further education to promote equitable care is even more critical. As an aside, I wanted to mention, for those of you who are interested in a deep dive on this subject, the National Academies of Science, Engineering, and Medicine are sponsoring a free virtual workshop on this topic next week. As I indicate here, even among providers with specialized training, bias is a challenging barrier to equity in patient care. Training in patient-centered care has the potential to reduce bias across many provider groups. One of the target areas highlighted in this paper is the opportunity for continuing education as well as education of healthcare trainees. The educational module that I am about to share with you can work for both of these groups of learners. These studies and others provide the context that healthcare providers are not immune to implicit biases. These biases have the potential to influence care of patients in a variety of groups, and the biases may be mitigated with appropriate training. Furthermore, assessment of the workforce highlights how critical it is for genetic specialists and non-specialists alike to develop the skills required to deliver genetic services equitably. These observations were the basis of Project Inclusive Genetics, which seeks to study the relationship between these aspects of providing care to individuals with high-risk pregnancies. Specifically, the goal of this study was to explore the presence of bias against people with physical disability among a heterogeneous group of healthcare workers and trainees. We then sought to evaluate the effect of this bias on clinical decision-making and whether there were strategies that could mitigate the effects of these biases. Now we'll briefly outline our study design. First, we asked participants to provide clinical recommendations regarding genetic testing for hypothetical prenatal scenarios. I'm showing here an example case on Becker muscular dystrophy. The case scenario provides some basic information on the clinical aspects of a diagnosis of Becker muscular dystrophy for context in case the participant is unfamiliar with the condition. After introducing the case, we follow up with a series of questions asking how the participant would advise the patients and what they would do if they were the patient themselves. In particular, the follow-up questions revolve around genetic testing and pregnancy continuation decisions. These paired questions allow us to examine the relationship between personal preferences and patient recommendations. Next, we assess the degree of bias harbored by each individual through both explicit and implicit bias testing. Let me describe what those evaluative instruments looked like. The explicit bias assessment consisted of 5 items reflecting negative societal attitudes. For instance, most people are uncomfortable around a child with a physical disability. These statements are difficult to read because they reflect overt bias. The participant then rates their agreement with the statement. These items were selected and adapted from other studies to focus on this study's population. Showing you screenshots of the implicit association testing, or IAT, for physical disability. The IAT measures word associations by timing responses to a categorization task. The bank of good or bad words and abled or disabled images are shown on the left. The participant is instructed to categorize the image or word in the center with one of the 2 descriptors at the top left or top right. The speed and accuracy with which the participant completes the task for a series of images and words is measured. If the participant has a mental association between the 2 words grouped together on the left or the right, this generally improves the speed and accuracy with which the task is completed. So if you look at this particular example, we see that the words from the bank that are for bad associations and the images for physically disabled are both grouped together on the left. So if somebody has an implicit association, lumping those 2 concepts together, they'll be faster to hit the key with their left hand than they would be if the words were swapped. The results are used to calculate an implicit bias score on a 7-tier scale, a strong preference for the categorical descriptor. For example, an individual may demonstrate a strong, moderate, mild, or neutral preference for physically abled or disabled individuals. After documenting baseline clinical recommendations, explicit and implicit biases, we then provided our own original interactive educational module on the principles of patient-centered counseling, with a particular focus on exploring patient-specific values. Here's an example of a case presented in the module with questions to prompt the learner and model ideal language during these types of discussions. The learning goals include 1, describe a patient-centered model for genetic counseling, 2, outline how to facilitate autonomous decision-making, and 3, apply knowledge of patient-centered genetic counseling techniques to clinical case scenarios. As participants work through this module, they are given practice with assessing patient needs and decision-making, clearly presenting risk information, exploring, respecting, and incorporating patient experiences, beliefs, and attitudes, engaging with the patient in decision-making, and utilizing an interactive style of counseling. Finally, we closed the study with a new set of clinical vignettes to assess clinical recommendations for genetic testing after our intervention. The cases in the vignettes were carefully chosen to provide clinical impact as similar as possible to the initial cases in terms of quality of life and lifespan. For example, you can see this case of ataxia telangiectasia was chosen to complement the Becker muscular dystrophy case in the first section of the module. We linked participant responses to IAT results and the collected demographic data to determine the impact of bias on clinical recommendations, as well as factors that mitigate its effects. The module lives here and is freely available to interested parties. So I encourage you all who are interested to go ahead and take a look after today's session, or share it with your trainees. We'd be delighted to be able to share this with you. Now let's take a closer look at some of our initial results. Phase 1 of Project Inclusive Genetics involved this initial sample of 335 participants. The largest groups represented are genetic counselors and preclinical MD students. The spoiler is that I teach the preclinical MD students, so many of them are my students actually. Underrepresented cohorts include physicians, medical geneticists, and other specialties, genetic counseling students, medical students in their clinical years, and allied health professionals. In this demographic information, we also ascertained previous connections to individuals with physical disabilities. First-hand experience was defined as having a personal history of disability or having a family member or a friend with a disability. Professional experience is defined as having had volunteer experience, clinical experience, or other. And one would expect for anybody who's specializing in the genetic space, they probably would have had some sort of professional encounter that's relevant to this training. Substantial fractions of the participants had personal or professional experience with this community. We wanted to collect this information because we felt there was a possibility it would impact implicit bias. As our next step, we wanted to determine whether physical disability bias existed in our cohort of healthcare trainees. Similarly to the existing data from physician assistant students and the general respondents to the IAT, we saw a strong to moderate preference for abled individuals. We also saw greater evidence for bias towards people with physical disabilities than intellectual disabilities. So for phase 1 of this project, we subsequently focused on physical disability. We next wanted to determine what factors might influence a participant to recommend genetic testing to hypothetical patients. We began by looking at initial testing recommendations in the first clinical scenario encountered by the participant prior to any engagement with explicit or implicit bias measures or the patient-centered counseling module. Explicit bias did not significantly impact clinical recommendations. All p-values shown here are greater than 0.05. However, respondents with greater implicit biases against people with physical disability were more likely to recommend prenatal genetic testing to patients who would terminate a physical disability positive pregnancy. This suggests an influence of unconscious bias on respondents' clinical recommendations prior to the module and implicit association test. In addition to the influence of implicit bias on genetic testing recommendations prior to our intervention, participants were more likely to recommend genetic testing to hypothetical patients if the participant would personally choose to get genetic testing for their own pregnancy, or if they would personally terminate a PD positive pregnancy. Interestingly, personal testing and termination preferences seem to have a stronger correlation with hypothetical patient recommendations. We then sought to determine if exposure to the IAT and patient-centered counseling module had any impact on the factors that were correlated with the likelihood of recommending genetic testing. After these interventions, the relationship between implicit bias and the propensity to recommend genetic testing was reduced to no longer significant. This finding was specific to scenarios where the patient would terminate their pregnancy, suggesting an influence of provider bias on ultimately pregnancy termination outcomes in the absence of patient-centered counseling recommendations. In contrast, the personal preferences for testing and pregnancy termination continued to be predictive of genetic testing recommendations, suggesting that those beliefs are not subject to modification by exposure to the principles of patient-centered counseling. We next assessed whether there were any respondent-specific factors that could predict whether a respondent would correctly advise a patient on prenatal testing. For these analyses, recall that the correct counseling recommendations are to offer and/or encourage testing when a patient would terminate a PD-positive pregnancy, and only to offer testing when a patient would not terminate a PD-positive pregnancy. In the instance when a patient would terminate, 99.4% of the respondents correctly offered and/or encouraged testing. Given the homogeneity in these responses, there was insufficient variability to perform additional analyses. Therefore, we focused here on the recommendations to the patient who would not terminate a PD-positive pregnancy or who would not disclose their personal choice around termination. We again used a series of logistic regression analyses and found that factors that predicted whether a respondent was more likely to correctly offer but not encourage or discourage testing included having a history of professional contact with people with a physical disability. Being a genetic specialist was also trending towards being significantly associated with correctly offering testing. Moving to the post-intervention analyses, we found that having professional experience no longer predicted whether a participant would correctly advise patients in the non-termination scenario. We also observed after our interventions, participants with an implicit bias against physical disabilities were more likely to correctly advise hypothetical patients, suggesting that these individuals were particularly amenable to supplementary training involving implicit association testing and patient-centered counseling education. Towards this end, when we compared clinical recommendations pre and post-module, we found that the intervention increased the number of correct clinical recommendations overall. When we subdivided the groups into biased against people with PD and biased for people with PD or a neutral preference, we found that our intervention was significantly more effective on individuals in the group biased against PD as compared to respondents who are biased for or neutral towards people with PD. We also see here that individuals with genetic specialization have a significant ability to correctly advise hypothetical patients, which suggests this module served as an effective refresher for this cohort. In summary, our findings confirm that the medical community, composed of trainees and providers in this study, harbor implicit biases that prove to be significant with respect to hypothetical clinical recommendations. In addition to these implicit biases, personal preferences for genetic testing and pregnancy termination also aligned with hypothetical clinical recommendations. Altogether, these findings suggest the importance of increasing exposure to individuals with physical disabilities and education on patient-centered genetic counseling. Specifically, we demonstrated that our module with an IAT can promote ethically appropriate decision-making and reduce the potential influence of personal biases on clinical recommendations. Importantly, those participants with baseline implicit bias against physical disability had greater improvement in clinical recommendations in terms of correctly advising the patients. To conclude, this study demonstrates how bias against a marginalized group exists within the medical community and that personal opinions can impact clinical counseling. Importantly, our findings suggest that there are strategies that can be easily implemented into curricula to address disability bias, including formal educational interventions and the addition of professional experiences such as service learning into healthcare provider training programs. In the future, we hope to further explore the impact of bias on clinical decision-making. We are currently in the process of recruiting more medical trainees, such as residents and fellows, as well as practicing physicians. In addition, our study is designed to assess both physical and intellectual disability. So in phase 2 of our study, with greater participation, we have preliminary analyses that uncover a similar impact of intellectual disability implicit bias on clinical recommendations. As availability of genetic tests continues to grow, the ability of providers to advise patients in an inclusive, unbiased way becomes increasingly important. Without this perspective, we risk inadvertent implementation of eugenic principles and the return to a paternalistic practice of medicine. If you're interested in using our educational module in your healthcare curriculum, Please feel free to reach out to me if you'd like any additional information. And you can also simply visit the freely available resource at this link or through this QR code. We would like to thank the AAMC Northeast Group on Educational Affairs and the NHGRI Inter-Society Coordinating Committee for providing the funding that made building this module possible. And I would also like to thank the extensive interdisciplinary team convened through the ISCC that supported this work at the intersection of clinical genetics, genetic counseling, ethics, and disability advocacy. Thank you so much for your attention, for the opportunity to speak with you today, and I'd be happy to take any of your questions.
Thank you, Shoumita. We're happy to open it up for questions. You can either put them in the chat or unmute yourself and ask the questions verbally.
There you go, Ashley. Thanks for your interest.
And just as a reminder, the meeting materials are all available on the MGN website, and a link was sent with your meeting invitation.
Also, I know it was a whirlwind of data, so if there's any data you would like to see again, that is also a totally valid question or comment, whichever way you view it.
So I'm going to take a prerogative and just ask you, Shoumita, what do you think are important ways that organizations like the Midwest Genetics Networks and our associated networks can assist in this educational mission, this strategy? What would you like to see us encourage on behalf of the genetics community?
That's a great question. I could go a lot of different directions with my answer, but in terms of your region, there's a kind of a wide landscape of access to abortion and pregnancy termination procedures. And what we found in this study is that for folks who have their own personal beliefs around pregnancy termination, for example, they're generally kind of imposing their own beliefs on the patient outside of what the patient actually wants. And in some of these legal contexts, the patient may not feel free to share what their actual decision would be in an ideal world. So clinicians may be operating in a situation where they actually don't have full information about what their patients desire to do with this knowledge, which suggests, according to this data, that actually having this foundation in patient-centered care and in eliminating bias from creeping into clinical recommendations is even more important because of that reticence for patients to share their own beliefs. So I think just really encouraging development, continuing education in this space, and having conversations like the ones that you're having at MGM today and tomorrow are absolutely critical to make sure that patients are able to be empowered to make decisions that are right for their own lives.
Yeah, I think it's easy to forget about the foundational nature of our recommendations for patient-centered counseling and how important that is in providing patient care that's meaningful and helpful to the patients we're giving it to. So
absolutely, yeah. And the other thing that really came out pretty strongly in these results is the really sort of powerful nature of having personal contact or professional contact with community members who are living with disabilities. So arranging for those kinds of opportunities for, just like today, for families to get together with clinicians is incredibly important to open the door for those conversations as well.
Yeah, I'm gonna put words in Matt's mouth, but one of the hallmarks of the work we're doing together is it's really about a wide variety of stakeholders, not just genetics professionals or public health officials, or that it crosses the whole spectrum of need in improvement in genetic care.
I think those were fair words
Thank you.
to put in my mouth.
Okay. I'm glad.
Yeah, I was going to add a comment to that conversation as well. Being a parent of a child with a genetic disorder, and also being a parent who during that pregnancy was encouraged fairly strongly to terminate the pregnancy, which we did not do. I can recognize, because I have so many close friends and colleagues that are clinicians, that clinician probably believed they were really acting in my best interest, to their core. Like I don't think there was any glimmer of I might have a bias in this situation. And I think that highlights, and you talked about this a bit in a lot of the data you showed, sort of highlights this as well, that this is not something that gets fixed today or tomorrow or in a week. It's going to take a long time of persistence and talking and training and talking and retraining and lots of conversations and lots of practice, that I think many times we, like as a genetics network, we don't have a good way to provide practice, right? Like there's, you either have a patient or you don't. So it's not really a spot for practice. So I think this was incredibly useful knowledge, and I would love to hear what especially any of our clinicians and you as well, Shoumita, would have to say about how we provide that practice in a way that helps clinicians grow, but is also safe for our families and our patients.
Well, first of all, I want to thank you for sharing your personal story. I think that words like that are so impactful because it's real lived experience. We do think that practice is incredibly important. It's something that in medical school, they're not so good at doing because you're sort of suddenly in there with your patient and you have to come up with the words. Genetic counseling training programs are better at this with a lot of practice and role playing and things like that. In preparing this module, one of the primary authors of the educational module itself is a genetic counselor, and she structured it. I'm going to just show you. She structured it in a way where you do get practice with putting your thoughts into words. So in each of these blue bars, what you can see are alternative ways to respond to the patients who are in front of you. So even though it's not a live practice scenario, it does give you a sense of, how would I actually try to describe something like this to a patient, to an invested parent? There are additional resources that have been developed through partnership with NHGRI, and I can try to look up those web links, but they are actual practice cases with video. So you sort of pause the video and you pretend like you're talking to the patient. So that's another opportunity to really kind of figure out what the right words are for these complicated scenarios. And then another thing that can work is I've heard of some institutions actually bringing in standardized patients so that folks get practice using using the language of clinical encounters with standardized patients. And in particular, the Massachusetts Down Syndrome Congress has a bunch of invested families whose adult children who are living with Down syndrome come in and serve as standardized patients. So you get real life experience there working with the intellectual disability community, and they provide a debrief at the end too. So the patients themselves, the standardized patients, will say, I really liked it when you made a point of talking to me instead of my parent. That was meaningful to me. Those kind of pearls are really important as a result of these sorts of training opportunities.
Thank you.
I see Amy is interested in that virtual role play. After this session, I will try to dig up that link and stick it in the chat for folks who are interested.
Perfect, thank you. And also the slides are on the MGN website. So if you're working on one screen and it was small, as you were viewing the presentation, you can see a PDF version of the slides on the website.
Yes, thank you. And I do want to say that the results that are published are open access, so they're available to everyone, including families.
Okay, I'm not seeing any more questions come in, but if they do, we will try to circle back with Shoumita later in the day. And we'll move on to Danielle.
Thanks, Sally. Thanks, Shoumita. I am going to announce our first trivia winner. Thank you for the very quick response. Chloe Meyer is our first winner, so we're very excited about that. Thanks for participating. We'll have more trivia to be played as we continue throughout the meeting. But for now, I believe I'm